Good morning, everybody. I am Dr. Dilip M Babu, consultant nephrologist and kidney transplant physician at Yashoda Hospital, Somajiguda, Hyderabad. This video I am making for the patient education who are planning to undergo a kidney transplant surgery. Kidney transplant is an option for the patients who have permanent kidney damage. Like once patient is diagnosed with a permanent kidney damage, then he will have two options. One option is to do a kidney transplant. Another option is to do continuous hemodialysis weekly 3 times rest of his life. Once we give this option to the patient of doing dialysis versus going ahead with the kidney transplant, it is the patient choice. But as far as the quality of life and long-term survival is concerned, kidney transplant is always the better options. So if someone is confused between deciding between the kidney transplant and the dialysis, and best option available for that patient is to undergo kidney transplant as far as the survival, long-term survival of the patient as well as the quality of life. Once patient decided about the kidney transplant, I want to tell you few things which every patient who is planning to undergo kidney transplant should compulsory know. So kidney transplant is planned if the patient is having the donor. Now donor may be one of his family member like brother, sister, mother, father or husband, or second degree relatives for his maternal side or from the paternal side. So these relatives whose blood group is same, suppose patient's blood group is B and someone is planning to donate from his family member whose blood group is B, that person from his family member can donate his kidneys to the patient. So any patient with blood group of O, patient's relatives who is having blood group of O, he can donate the kidney to the patient. So the person who is donating kidney either should have same blood group or blood group O, because O blood group person can donate the kidney to any person. So first thing what we do is, once someone from the family member of the patient comes forward for the donation, we check the blood group of the donor as well as the patient. If blood group is matching, then we do further tests. Remember, the patient who is having patient's relatives who is having blood group O, he can donate the kidney or the same blood group. If once donor is decided, next step is to do the investigations. We do all the blood tests as well as the total body checkup of the donor. Like we do their cardiac checkup, their pulmonology, that lung status, we check their blood pressure, blood sugars and all the vital parameters as well as all the investigations before finalizing them as a donor. So donor has to undergo investigations as well as few fitness tests from cardiologist and pulmonologist. If the donor patient is a female, we'll tell them to do gynecologic checkup also. So donor, they will have a lot of doubts what will happen after donating one kidney to them. So usually 1 in 10,000, usually 90-95% the person who is donating the kidney, they will not have any problem in future. They can do all the work, they will not have any diet restrictions, or they need not have to take any medications after the donation of the kidney. Usually we do all the tests for the donor, then only we'll accept them as a kidney donor. So first thing is, we'll check the blood group whether it is matching with the patient. Next test, we do all the investigations, blood, urine test as well as their heart checkup like ECG, 2D echo. We check if their lungs by doing chest x-ray, pulmonary function test. We'll do the viral screening test for the donor and then finalize. If they don't have BP, they don't have sugar, they don't have heart disease, then we finalize them as a potential donor. So donor, we remove only one kidney, and that kidney, which kidney has to be removed from the donor is decided by tests like DTPA renogram and CT renal angiogram. These two tests we do routinely for all donors to find out which kidney has to be removed and which kidney has to be kept in the donor. So after doing these two tests, DTP renogram and CT renal angiogram, we decide which kidney has to be taken. Usually the donor kidney usually we remove donor kidney by doing laparoscopic nephrectomy. It is a small incision surgery. So with that small incision we remove the donor kidney, and usually donor, after the surgery they have to stay in the hospital for 2 or 3 days. Once their condition stabilized, we discharge them. They can go back to their normal routine activities 7 days after the surgery. We usually advise donors after the surgery to come after 6 months initially, and every year we want them to routinely do all the checkups like BP, blood pressure, sugar and their kidney function test. Usually 1 in 10,000 patients who has donated their kidney on the long terms, by the end of 10 years, 15 years, if they develop diabetes or hypertension, that single kidney may get affected. But if they take care of their weight and blood pressure and sugars, they will be as normal as any other person. But the donors, we usually advise them to follow up at least once in a year for routine checkup after the kidney donation. Now as far as the kidney recipient, like kidney transplant recipient, where we put a kidney of the donor, usually there are doubts that whether the native kidneys, the doctor will remove my original kidneys or not. No, normally we don't remove the native kidneys, the original kidneys, which are usually very small and non-functional. Only few conditions where we remove the native kidneys are polycystic kidney disease, or patient is having kidney stones and infections, or kidney size is very large and it is infected, then we remove the original kidneys. And usually in other kind of patients, normally we don't remove the original kidneys. We put extra kidney near the lower part of the abdomen. This kidney will be anastomosed to the recipient's recipient's artery, vein and urinary bladder. So there will be 3 connections. The donor artery is connected to the recipient artery, donor vein will be connected to the recipient vein, and donor ureter will be connected to the urinary bladder of the recipient. So these 3 connections will be made. Usually this surgery is done under general anesthesia, and the patient is closely monitored after the surgery for any other surgical complications. So I want to discuss few things about surgical complications after the transplant in the recipient. Usually, as I told you, there are 3 anastomosis. One is artery, one is vein and one is the ureter. So sometimes there may be blockage to the donor artery or block into the vein, or there may be some urine leak from the ureter. So these leakages or block of these 3 connections may happen immediately after transplant, but we usually closely monitor them for these complications. If these complications arise, we immediately shift them back to the OT and remove these obstructions by doing another surgery. But these complications are quite rare, but these complications are known to occur in few patients, like you can say 1 in 1,000 cases we found out these type of complications. Another complications which we face after the kidney transplant is the rejection. Immediately, sometimes we see after putting the donor kidney, the body may not accept that kidney immediately on table. The kidney will turn suddenly into the blue. So that is called as hyperacute rejection. This kind of rejection may occur immediately after the surgery, or during the first week, or 3 months or year. So rejections may happen anytime. So but first 3 months are very important, as these 3 months there is high chance of rejection. So this is one of the possibility after the kidney transplant, that recipient's body may not accept that kidney, which is called as rejection. Now to avoid these rejections, we give some injections and tablets which usually we start before transplant only. These medicines like tacrolimus, mycophenolate and steroid injections, as well as sometimes we use few injections like Simulect and thymoglobulin at the time of transplant or after the surgery to prevent these rejections. With these kind of medicines, rejection rates have come down significantly. Now rejection, even if the rejection happens after the transplant, Usually we try to do a transplant kidney biopsy by removing a small piece of the transplanted kidney and checking it whether it is a rejection or not. If it is rejection, we usually treat with again few other medications like steroid injections, with which rejection can be reversed. Only 1 to 2% cases where rejections may not respond to any standard treatment and patient's kidney may get failed and they will go back to the dialysis. So sometimes this kidney, which after immediately putting after the surgery, this kidney may not start functioning immediately. This type of kidney failure we call as delayed graft function, where we have to give some time to the transplanted kidney to start functioning, and in this period we do dialysis, 1 or 2 sessions of dialysis till the kidney starts working. This is called as delayed graft function. These also complications sometimes we face immediately after the transplant. After the transplant, patient has to take these immunosuppressive medications like tacrolimus, mycophenolate and steroid tablets rest of their life. If they stop these medications any time after 1 year, 2 year or within a 1 year, the body may reject these kidneys and the patient will come back to the dialysis. So we will give the instructions to the patient not to stop any of these medications after the transplant, because once you stop these medications for 1 or 2 days also, the body may reject these kidneys and your transplanted kidney may get failed and you will come back to the dialysis. Another complications what we face immediately after transplant is the infections. Infections may occur at the surgical site where we put a kidney, or because of the urine leak sometimes happens and patient will start leaking at the site where urine tube is connected to the bladder. This is called as urine leak, and these infections may happen at the surgical site, or infections may happen into the lungs, infection may happen into the urinary tract. So these infections are caused by usually bacteria, but sometimes rarely we have seen with the virus like cytomegalovirus and fungal infections also, which may affect your lungs, your kidneys, your abdomen or surgical site wound infections. If these infections happen, we have to give antibiotics. If it is a virus like cytomegalovirus, we give antiviral medications like valganciclovir. If it is fungal infection, we give antifungal medicines. But these infections sometimes becomes, even after giving the antibiotics and antiviral and antifungal medicines, these infections sometimes is life threatening, which may cause patient may lose the life because of these infections in spite of giving all these antibiotics. So there are chances of death if these infections occur, but we usually take the precautions to avoid such kind of infections by giving prophylactic antibiotics to prevent these infections. Third problem, which is quite common after the transplant, is the recurrence of the original disease. Like recurrence means the original kidneys which has been damaged by some disease, the same disease may come into the transplanted kidney, which is called as recurrence. Like few diseases like FSGS or some glomerular disease which recur in a higher percentage, like 30-40% or 60% cases we have seen these diseases come into the transplant kidney, and we treat for these diseases, but still sometimes we may lose the transplanted kidney because of this recurrence of original disease in the transplanted kidney. As far as these complications are concerned, these are known to occur in 5 to 6% of patients out of 100. We have seen these complications 5% cases, but these complications are known to occur. So every patient who is planning for kidney transplant should know all these complications after the transplant. Another thing, after transplant they have to follow the regular checkups, like first every week 2 times we call the patient for first 3 months, and then every week till 6 months, and then every 2 weeks till 1 year after the transplant. Even after 1 year we call them every month for routine checkups. So every patient should know they have to come regular for checkups. We check up their urine, creatinine levels, hemoglobin levels, cholesterol levels regularly to preserve that kidney, and we can detect if any early kidney damage is because of early rejection or any infection. We can detect it and treat it. And patient has to take these medications like tacrolimus, mycophenolate and steroid rest of their life. They can't stop these medications. If they stop these medications, their transplanted kidney may get rejected and they will come back to the dialysis stage. So they have to follow some dietary precautions. As far as quality of life is much better as compared to as they are on dialysis. They will have freedom of eating, there will be no dietary restrictions. Predominantly if the patient is having high blood pressure or sugar, they have to control the diet for blood pressure and sugar, but kidney functions will be normal. Their creatinine will come down to normal after the transplant and their quality life will be much better. So these are the usually this video I have prepared for the educating the patients, because they should not plan for the transplant before knowing all these things. So best of luck to all the patients. Thank you.